Dr. Eric Crawford, and I'm just going to read his bio just a little bit. You have your bios in there, but I just couldn't not do this. Dr. Crawford currently operates as the Acting Chief of Staff for the Sheridan VA healthcare system. Prior to transitioning to the Sheridan VA system in late 2015, Dr. Crawford spent nearly a decade contributing as a clinical psychologist in the VA's Mid-Atlantic Region Mental Illness Research, Education, and Clinical Center and the Durham VA Medical Centers. I'm going to let Shelley tell us what OEF, OIF, and OND programs are because they're acronyms.
The VA runs on acronyms. And so OEF is Operation Enduring Freedom. OIF is Operation Iraqi Freedom. And OND is Operation New Dawn.
So these are all programs with the VA. He also served as an assistant professor within Duke University's Department of Psychiatry and Behavioral Sciences. Dr. Crawford has been an investigator and clinical consultant on randomized controlled trials of chronic PTSD treatment and has contributed to the recent research on the effectiveness of trauma-focused psychotherapy. Let's welcome Dr. Eric Crawford.
Well, that was a very flattering introduction, so I want to thank Stella for that, and want to thank you all for being here today and joining me for a conversation about post-traumatic stress disorder, options for treating the condition, and tips and tricks for caregivers of veterans or other folks suffering from post-traumatic stress disorder.
As Stella mentioned just a little bit ago, I'm currently operating as the interim chief of staff for the Sheridan VA healthcare system, but the lion's share of my career in the VA, which is now an 18-year career, has been spent providing direct services to veterans suffering from post-traumatic stress disorder, as well as their family members and caregivers. And it really those experiences as a clinician and a researcher that I'll be drawing from today during this presentation. And I don't expect this to be a lecture about PTSD or caregiving issues around PTSD. I think it's probably going to be more useful if it be an interactive venture, a conversation between myself and you all about the condition, how it impacts people, and what great treatments we have to offer for folks that are experiencing symptoms of post-traumatic stress disorder. So one thing I want to just make totally clear is that if there's anything that I'm saying that doesn't make sense to you or something up on the slides that you have a question about, please don't hesitate to stop me and ask me a question about it. Or if you have a personal anecdote or situation that you think is relevant to this conversation, I'd be happy to discuss that during this conversation today too. So is everybody okay with that? Okay, great. So I'm going to cross my fingers and hope that the clicker works. We'll see if we can get started. Okay, so but I want to spend the lion's share of the time today talking about treatment and useful strategies for caregivers and veterans or other folks that are experiencing symptoms of PTSD. But I want to take a little bit of time just to talk about the disorder itself, how common it is, and what the symptoms are that are associated with this condition. And usually when I talk about post-traumatic stress disorder, one of the things that's important for me to get across is how rare the condition actually is, even among veteran populations. So I think there sometimes is a sentiment in the community that anybody who's exposed to traumatic events or combat, or a large percentage of those folks are going to develop these symptoms and will have difficulty functioning. And that's simply not the case. If you look at the entire US population, which the figures at the top of the slide are in reference to, it's really a very small percentage of folks that are exposed to traumatic events that develop the full set of symptoms of post-traumatic stress disorder. That is also true of veteran populations. So if you can look at the bottom half of the slide, there are some figures for the percentage of veterans exposed to traumatic events like combat, wartime experiences during different eras. You can see that the percentages of veterans that develop a full-blown PTSD disorder are actually very low. That percentage tends to fluctuate between 15 to 20%, depending on how many traumatic experiences somebody accumulated during their term of service. So if you look at Vietnam, about 10% of veterans that participated in that wartime conflict still have current post-traumatic stress disorder. The percentage increases to about 20% if you look over the lifespan. Has somebody ever had this condition? But many people recover from the condition naturally without treatment. So I think that's important to talk about. One of the things that has been clear in the population that I have worked with the most in my career, which as Shelley mentioned, was veterans from Iraq and Afghanistan, is that the percentage of veterans from those conflicts that develops post-traumatic stress disorder has increased as the years have gone by. So if you look at the studies that were done very early in operations enduring in Iraqi freedom, is really low, a relatively low figure, around 10 to 12% of veterans that were reporting these symptoms. But that number has increased significantly as the number of deployments has markedly gone up in that population. So one of the things that's unique about our current military is that it's all volunteer. So it's an all volunteer force. And as of a couple of years ago, the war in Afghanistan was already the longest war in all of US history. So when you have extremely extended conflicts and an all volunteer force, what do you think happens? Thank you. All right, so the same force is being redeployed at tremendously increasing rates. So it's a fairly common situation for me or a clinician at the Sheridan VA to encounter a veteran from Iraq and Afghanistan that's been deployed 5 times. That you just didn't see those rates of redeployment during some of the earlier conflicts. And one of the clearest indications from the research on PTSD is that the more combat or the more other types of trauma you accumulate, the more likely you are to have lasting symptoms that require treatment. So we're really kind of at a unique time in the VA and in the United States in terms of treatment of this condition, is that we're seeing folks have the disorder at greater rates than ever before because of the amount of redeployment. Any questions about that? Or I would also ask, does anybody experience that personally and interacted with a veteran who has been deployed a number of times and seen that take its toll? Anyone? Sure, Carrie, can you comment on that? Right. And another very common situation with the wars in Iraq and Afghanistan and the way that they take their toll is that there can be accumulation of trauma, but because of the method of attack from the enemy, there are also exposure to blast injuries and physical sequelae, much more so than other eras as well. So because of that, we're seeing more PTSD, and one of the things that I particularly am happy about is that we have great technology for treating the disorder, and I'll get into that in just a little bit. One final note about prevalence with PTSD is that it's very uncommon for somebody to come into the VA for PTSD treatment and not have any other psychiatric conditions. So there's a really high comorbidity rate between PTSD and other psychiatric conditions. It's more often the case that somebody has that disorder plus another anxiety disorder, depression, or other psychiatric conditions. So there tend to be a lot of complexity. Yeah. Comorbidity simply means that you have more than one condition. It's, like I said, it's very unlikely that somebody has only post-traumatic stress disorder, and that's the only condition that you need to treat. One of the good news items that I'll talk about though quickly is that when you effectively treat post-traumatic stress disorder, almost all of the other conditions that somebody has typically get better as well. So that is good news, and we'll talk more about treatment here in a little bit. Okay, and so like I said, I just wanted to take a couple of minutes to talk about what PTSD symptoms are and how they're captured diagnostically. And the basic requirement for somebody to be considered for a diagnosis of post-traumatic stress disorder is that there has to be some exposure to traumatic experiences. And those traumatic experiences, by current diagnostic criteria, have to be personally experienced. And it could be combat, it could be physical assault, it could be a personal violation, it could be the threat of any of those things. But there needs to be exposure to traumatic experiences. Or, by the current diagnostic definition, you can also be a witness to those kinds of experiences to others, and particularly to family members and close others in the social support network. Those kinds of exposures can lead to the full symptom set for PTSD. So all of the symptoms that I'm going to talk about in a little bit that are part and parcel to PTSD must be linked with specific traumatic experiences for a patient or a veteran to receive that diagnostic determination. One other new aspect of the current diagnostic criteria for PTSD that's probably worth discussing is that the new criteria allow for people during the course of their jobs with repeated indirect exposure to traumatic stimuli. And there are some examples listed on the screen, whether that be police officers that are regularly exposed to detailed of childhood trauma, or other first responders encountering the aftermath of traumatic experiences. Those experiences over time can qualify for a diagnosis of PTSD too. And this is particularly important for veterans because more and more of warfare is being accomplished through remote or indirect means. And one example of that would be drone strikes, which are becoming more and more commonplace in warfare in regions throughout the Middle East. And the current diagnostic criteria allow for folks that are exposed to traumatic experiences via video or drone strikes, things of that nature, can qualify for the disorder as well. And I think that is an important update to the diagnostic criteria. So let's get into real quickly what the symptoms of PTSD actually are. So the first and foremost, the hallmark symptoms of the disorder have to do with reemergence of traumatic memories. So the traumatic events that have been experienced, whether it was a natural disaster, combat-related experiences, a personal assault, memories of those experiences tend to operate differently than other memories that we all have day to day. And those memories tend to, in an involuntary way, intrude on the veteran or patient's consciousness involuntarily, often at moments when they least expect it. So it's a very different kind of experience of memory than we all have day to day. So just to draw a distinction around normal process of encoding memory and what happens with folks with PTSD. So is somebody willing to share with the crowd what they had for breakfast this morning? Anybody? What's that? Okay, oatmeal. So I want you to just take a second and think back to that experience of eating oatmeal for breakfast this morning. And take us through it. Maybe take 30 seconds to describe what was going on in that situation, what it tasted like, etc.
My husband made oatmeal. I put some milk in it because it was a little dry by the time I got to it. I
Right, so you can on purpose think back to those moments earlier today, and you can recall a lot of sensory information. It makes chronological sense to you. You can do that on purpose and volitionally. When traumatic memories come up for patients that have post-traumatic stress disorder, it's very different than that. There is not a volitional aspect to it. There's no control, which you demonstrated very well just now. There is also, as you're sitting there describing this to us, you know you're in this room here with us right now, thinking back to that experience of breakfast, right? So with veterans or patients that have PTSD, there's an important difference there. One is that they don't experience control of these memories. These memories come back to them outside of their volition, most often in a surprising way when they're least expecting it. And there's also a marked difference because it's very difficult for folks with PTSD experiencing intrusions to understand that that's not happening right now. It's much more difficult for them to make a distinction between the present and when that memory happened, that it's an actual memory. They feel often as if it's happening again with an intense surge of adrenaline and other negative emotional states that were often present at the time of the trauma. And what is a basic facet of the disorder, and one that we always go after in treatment, is trying to help the veteran or the patient work towards processing those memories, processing them and being able to incorporate them or file them with the rest of the memories that they would have. And so I'm gonna try to illustrate the difficulty of doing that with another exercise, if you'll permit me. So where do most of you go shopping for groceries in Sheridan? Is it some people Albertsons? Can I get a show of hands for Albertsons? Okay, what about Ridley's? Okay, so it looks to me like most people are Albertsons people, so I'm going to use that as the example, okay? Part of the reason why traumatic memories are so difficult to process or to encode and file is because they're so different from the other experiences that people have during the course of their lifetimes. So they don't, if I could put it using a metaphor, there are no files existing in your file system for events of this type, because they're so far outside of your typical experience. And so I want to try to illustrate that with an exercise real quick. So I want you all to think about, pulling your car up to Albertsons, heading in to do your normal shopping for the week, and maybe, you head in the door, you've got your cart, and immediately, upon going into the produce section, you see a clown. And the clown is juggling, all right? So does anybody have any reactions to that? Like any immediate thoughts that you might have if that's what you see in the Albertson store? Yeah. Okay, so we might have a clown phobia in the crowd. Any other immediate reactions that people would have to that? Which is, how might it feel? What feeling might you have? Okay, who said that? Okay, so you might be confused. Would anybody be surprised to see a clown juggling right next to the cheese aisle in Albertsons? Okay, so let's take this just a little bit further. Let's say you're like, okay, I don't know what the hell's going on there, but I'm gonna go about my business and I'm gonna keep shopping. And you go back to the back where the meats are, and you see a tiger on a leash next to the meat section. So again, what reactions might you have?
I don't eat any meat.
Okay, no meat today. Maybe fear. And also, would you continue to be confused? Okay, so you probably continue that confusion. I'm going to take a final step, and this is where I'll stop, I promise. So I want you to think about, okay, you see the tiger, you see the leash, you don't know what to make of it, you turn left and you go down to the seafood section, and then you see a ringmaster dressed up in ringmaster's clothing with a whip in hand. So what determinations might you begin to make? Okay, so we naturally, as humans, try to make sense of the information that's presented to us. And we come up with reasons why different things exist in these different environments. And if we can come up with a reason, if you see enough of that stuff and your final determination is, oh, okay, the circus is in town. This kind of makes sense. You might be able to file that memory away, and it probably wouldn't be so intrusive to you. But if you have no frame for understanding what's happened or making sense of what's happened to you, and it's completely out of your experience, that memory would tend to intrude for you or stick out. You might not ever forget that day where you went into Albertsons and you encountered the clown and the tiger on a leash, right? It might stick out for you. And that's one of the things that happens with traumatic experiences and memories, is they're so outside the normal human experience, they're very difficult to process, make sense of, and put to bed mentally. And the lack of processing is represented by these intrusive symptoms. The way we conceive of this as mental health providers is that this is the mind trying to make sense of these events that don't make sense. Over and over again. And the way that they come back is a variety of different ways. Nightmares, flashbacks during the day where you actually lose track of where you are, maybe just the feelings that you felt at the time popping up for you out the day inexplicably. All of those are ways that those memories intrude. And this is a hallmark of the disorder. And it's a key of treatment too, which I'll get into in a minute. Okay, so the next set of symptoms, and probably the most important ones that I can talk about with anybody, is avoidance of memory and of things in the environment that remind you of those traumatic experiences. So every veteran with PTSD or every patient that I've ever treated with PTSD makes a concerted effort, a day-to-day, hour-to-hour, minute-to-minute effort to make those memories go away, or to do what they can to avoid those memories, because they're often extremely painful. And so that prevents a lack, so it introduces a lack of processing. If you always try to get away from that memory, to erase it, maybe with alcohol or other substances, maybe you just distract yourself as much as you can throughout the day. Yeah. So what it can look like is somebody getting really upset anytime somebody brings up something that might remind them. It can also look like folks not wanting to talk to other people about anything that might pertain to their military experience. Or it might look like somebody trying to keep themselves engaged and busy at all times. And does anybody know any veterans that might have some symptoms of post-traumatic stress disorder that never stop? Okay, so I see some hands raised. And that's often an effort to eliminate those memories or keep them at bay. Now, it's not just memory, though, that folks work really hard to keep at bay. It's often things in the environment as well that might remind them of those traumatic experiences. The clearest example that I have in my career was a veteran that I treated that was never exposed to combat. So this veteran has probably had the most severe PTSD symptoms that I had ever seen in my clinic, and he had never been deployed. While off base on the eastern seaboard, I just stopped at a gas station. I don't know if anybody's familiar with the Northeast, but anybody familiar with Wawa stores? All right, so it's kind of like a convenience gas station type store that's very prevalent throughout the Northeast. So my patient, he stopped at the Wawa, and he was hungry, and he was getting gas, and so he went into the Wawa just to get a snack. And to continue on his road trip that he was on when he was on leave. And he bought these things called Ptsd cakes. Is anybody familiar with Ptsd cakes? You are? They're delicious. They come in a variety of flavors. They're like a pastry that's often sprinkled, with sugar and other kind of delicious stuff. So my patient bought the Ptsd cakes, went up to the counter to pay for them, and he just happened to be in the store right when it was being robbed. So the perpetrator assailant came in the front of the store while my patient was walking up to buy the Ptsd cakes and immediately shot him in the chest with a 9mm and robbed the store. And it was really just a miracle that my patient didn't die. The EMTs got there very quickly, got him into the emergency department at the local hospital, and they resuscitated him. But he, as you might imagine, had a number of intrusive experiences about being shot, about the feeling of being shot, and also being on the ground and watching what was happening as he thought that he was dying. And so let me ask you this. What do you think happened any time thereafter that he encountered Ptsd cakes? Somebody speak up. What's that? Okay, flashback. So pretty much every time he saw an ad for Ptsd cakes, anytime he recalled what they tasted like, anytime that he drove up to a Wawa, before we participated in treatment, he often felt like he was dying in those situations. And if that's the feeling that you have, what might you do about Ptsd cakes or Wawas? You might stay the hell away from them. And that's what he did. So there was always an effort to, I'm never going to go to a gas station again. I am never going to eat anything that reminds me in any way, shape, or form of that experience. If I hear a jingle that reminds me of it, I have a really strong response. And so we all know, at least I hope we know, that a picture of a Ptsd cake is not lethal. It's not going to kill you. Ptsd cakes might kill you in the long run, but eating a Ptsd cake is not going to kill you in the moment. But that's how he felt. He felt like every time he encountered that stimulus that he was going to die. And one thing that's extremely important if you're going to do a successful treatment is to help the affected individual understand again that a Ptsd cake jingle is not lethal, that a sign of a gas station is not going to kill you, so that you can function again. And that's why this particular set of symptoms is so important for treatment, because it's the avoidance of the memories and avoidance of reminders and situations in life that keep these symptoms alive. And I'll talk a little bit more about that. Okay, so the next set of symptoms that have to do with PTSD involve really strong negative emotions like guilt, anger, depression, horror, fear, those kinds of things, as well as the development of a common set of beliefs about the self and the world. And I've highlighted a couple there because they're particularly important with treatment. And if you talk to folks that have PTSD long enough, one of the things that you will often hear is that there is a really significant mental effort to try to think about ways to undo something that has already happened. So does anybody know any veterans maybe with these type of symptoms that will tell you or that will communicate, if only I had done X, this never would have happened? Or, if I had hit the gas instead of the brake, if I had used the radio 2 minutes before, if we had taken a different route on the convoy. Has anybody heard stuff like that? Okay, so some of you. So that there often is that kind of way of thinking. If only I had done X, this event would not have happened to me. It's a mental undoing. And the problem is there's no way to undo it because it's already happened. And that way of thinking can keep symptoms alive as well. In addition to that, there are often beliefs about other people and the world as a whole that develop with this condition. One of the real common ones is that danger is everywhere. Like my patient that bought the Tasty Cakes. So eventually, over time, he grew very strongly to believe that there were no places in the world that were safe. Does that sound familiar to anybody? Or that no one can be trusted? Yes? Okay. So one of the things I want to point out really quickly is that if you believe that the entire world is dangerous and that there are no safe places, what might you decide to do more of? What's that? Find a cave, a cabin maybe, up in the mountains, or wherever, a bunker. Some people have a shed, that's in the back of their residence that they spend an awful lot of time in. These types of beliefs, like the whole world is dangerous or nobody can be trusted, often go hand in hand with avoidance of the world. And the more that you avoid the world, the more that you can become convinced that the entire world is dangerous. So those things go hand in hand, and they're targets for treatment, which again I'll get into in a minute. Any questions about the symptoms that I've discussed so far, or these beliefs that can come up for people with PTSD? Yeah. Excuse me? What about them?
Yeah, how is that similar?
Well, like I said, it doesn't.
What she said, we can't hear what
Do we have another mic so that people can ask questions? So I think Carol's question was about childhood traumatic experiences and what if any, differences?
Yeah, is it the same? Would there be the same kinds of reactions and things going on?
Yes. So thank you for bringing that up. It's a good question. There really is little difference between the stage of, what stage of development you experience a traumatic event in and whether you develop post-traumatic stress disorder. Events that are experienced in childhood, adolescence, adulthood, they can all lead to these kinds of experiences and symptoms. And like I alluded to before, the more traumatic experiences that happen to you, the more likely you are to develop the full condition. So if you have a tremendous accumulation of childhood trauma, your likelihood of developing PTSD is greater. I'm not sure if I'm answering the question though. Okay, all right. The final set of symptoms that have to do with PTSD are basically what we call hyperarousal. And that is that folks that have experienced traumatic events and have the full condition, often the adrenaline system is on a hair trigger. Your baseline heart rate, blood pressure, adrenaline flow is higher than folks that don't have the disorder. So there's really a hair trigger with that adrenaline system. It puts people with PTSD very close to like a fight or flight response, where your body and your mind are prepared to either get you away from danger or to deal with it aggressively. So that hair trigger on the adrenaline system comes with a variety of negative consequences, and some of them are up there on the slide. So many veterans with PTSD have a high level of anger and irritability, which can be very difficult to deal with for caregivers. I don't know if anybody in the crowd has difficulty dealing with a caregivee that has anger issues. Can I get a raise of hands? Okay, so at least some of you. This tends to also be one of the most distressing symptoms for the person experiencing PTSD. And really, many of them feel terribly about having this experience. But if your adrenaline is always on blast, it's often very difficult to calm yourself down. So that's a very common symptom of hyperarousal. Another one that we see on a frequent basis is reckless or self-destructive behavior. Things like getting on a motorcycle and driving 100 miles an hour down the highway. Maybe, finding yourself instigating a lot of fistfights. Sometimes people engage in promiscuous sexual behavior, but there's that adrenaline chasing that can go with this condition too. And I'm sure that most people have heard about hypervigilance, just being on alert at all times, situationally aware with your head on a swivel, trying to make sure that you understand every potential threat in the environment so that you can counter it if need be. And the classic exaggerated startle response to like loud noises, unexpected happenings. All of those are symptoms of having that adrenaline system really, really high at a baseline level. And as you might imagine, if you're really ramped up most of the time, it's very difficult to sleep. And as all of us know, if you don't sleep very well for a week, 2 weeks at a time, months at a time, what do you think happens to you? What's that? Yeah, your brain goes to mush, you feel terrible physically, your pain gets worse. So sleep is a real problem for folks with PTSD, and again, we'll talk about that when we get to treatment. Okay, well, any questions about symptoms before I get into some treatment factors? Okay. Well, as I said, I'm going to talk a little bit about how symptoms develop and what we go after in treatment for this condition. And one of the things I would like to point out too is that even though very few people develop chronic PTSD after exposure to traumatic events, almost everybody has some symptoms after experiencing a life-threatening event. So there's been a number of studies that have followed veteran units during combat deployments or assault victims immediately after they were assaulted. And the vast majority of them have some of these symptoms, particularly the re-experiencing and the hyperarousal symptoms. So, and when I say the vast majority, I mean like 90% of folks that are exposed to traumatic events, they start having those re-experiencing and hyperarousal symptoms. If those folks don't get caught in avoidant practices and they don't shut out memory and they don't start avoiding the world and all of the relevant reminders in the world, often those symptoms naturally recede over time. So if you follow those folks for a couple of months, that 90% falls to about 15 to 20%, like the numbers that we talked about earlier in the presentation. But what happens for most folks that have chronic PTSD, and I'm going to try the laser pointer. So almost everybody starts experiencing, the reminders of the trauma and those hyperarousal symptoms. And the problem happens usually when folks begin getting into avoidant habits, avoiding those memories, pushing them away, blocking out those kind of cues and situations that might remind them of the traumatic experiences. They often have more and more of those beliefs that I talked about earlier. Nobody is to be trusted. Something is wrong with me, that this happened to me. The whole world is dangerous. And what happens there is often the beliefs get worse and worse, and the avoidance becomes stronger and stronger. And it leads to this vicious cycle. And for about 15%, 20% of people leads to chronic post-traumatic stress disorder. So I'm going to talk very quickly about, before we get into the specifics of treatment, of how treatment works with PTSD. And what we do in PTSD treatment is that we really try to go after one of two different things, or both of those two different things, to shut down symptoms or lead to improvement. What we do in folks that have chronic re-experiencing and hyperarousal is we try to, in a way that's comfortable for the veteran or the person that has PTSD, begin moving towards those cues and situations again, so that they can understand, like my veteran ultimately did, that a picture of a tasty cake was not going to kill him, that not every gas station was going to result in near death. So we really try to go after avoidance of memory, avoidance of cues, and then the other most effective treatment for post-traumatic stress disorder really emphasizes going after those beliefs, that no one can be trusted, that the entire world is dangerous, that somehow another person would have prevented this thing from happening. That's the way that we go after PTSD symptoms, is that we go after avoidance and we go after beliefs. And for most people that pursue evidence-based treatment for PTSD, if we can do that successfully, we can shut down or have drastic improvements in hyperarousal and those intrusions. Okay. So hopefully, if we can hit the beliefs and we can hit those avoidance mechanisms, we can get you on the path to recovery. And that's really what our best treatments do. So I want to talk just a little bit about our best treatments for post-traumatic stress disorder. They are, without a doubt, the best treatments are talk therapies, believe it or not. Many people, when they think of psychiatric conditions, they think that they automatically think of pharmaceuticals. There's a pill to take that will improve these symptoms. And the research clearly shows, without a shadow of a doubt, that our best treatments for this condition are psychological, behavioral talk therapy treatments. And the ones that we use the most in the VA are the ones that are up on the screen there: prolonged exposure, cognitive processing therapy, and there are also some other talk therapies that have really good results with PTSD. And I'm going to talk with you about some of the specifics of those treatments just in a minute. I don't want to completely downplay medications, though, because there are some medications, sertraline and Paxil among them, that have demonstrated some benefit for treatment of PTSD. Usually what the medications do is they can turn down the volume on some of these symptoms, but very rarely, if ever, do medications lead to lasting remission of these symptoms. The treatments, the psychotherapies that I'm highlighting on the slide there, those results often stick if somebody is able to complete those treatments. And in terms of how effective they are by comparison, usually get about double the effect of medications with the talk therapies. So one thing that I want you all to be thinking about is if you run into folks or you provide care to folks that have these symptoms, is how you might work with them to engage in one of the treatments that works the best. And we'll get to that. Okay, so I've got a few formatting issues because I got a Microsoft package to create these slides, and we're using a Mac, so you're going to see some stuff get a little rejiggered and messed up here along the way, and I'm hoping some animation that I've built into some of these slides works, but we'll get to that. So prolonged exposure therapy is probably the treatment that most directly goes after avoidance with post-traumatic stress disorder. So it has been around since the late 1980s, and there are now more than 35 randomized controlled research studies that suggest that this treatment is very effective for PTSD, regardless of your trauma type or what population we're talking about. Veterans, female assault victims, folks that have suffered through natural disasters. Regardless of trauma type or subpopulation, this treatment has demonstrated great effectiveness. And the way that it lays out is it's typically 8 to 15 sessions with an individual therapist. Each of those sessions is 90 minutes in length. And the primary components are, one, some of what I'm trying to do with you here in the early part of this presentation, providing some education to the patient and their family members if necessary about PTSD, what the symptoms are, what keeps it around. And then over the course of the next 7 to 14 weeks, you spend a lot of time working with the patient to figure out how you can begin successfully moving towards those cues, those reminders, those situations in daily life, and then systematically confronting in a way that's comfortable for you to do so with the support of a therapist those traumatic memories that you try to get rid of in every way possible. So that's really the basics of that treatment. And like I said, it has been proven to be tremendously effective. I have been using prolonged exposure therapy since 2004. I've treated hundreds of veterans with that modality and have had tremendous results. So it's something that I want you to try to remember, prolonged exposure. Remember that. Also, even though, again, the slide is a little bit offset there, the other best talk therapy treatment that we have for PTSD, and this is a little bit newer. The first the study with cognitive processing therapy was done in 1992, but there have been upwards of 10 randomized controlled trials with this treatment that have demonstrated tremendous effectiveness in veteran populations and non-veteran populations. And there are some subtle differences between prolonged exposure and cognitive processing therapy. Prolonged exposure goes after avoidance directly. Those cues, those memories. There's a little bit more of an indirect approach with cognitive processing therapy. There is an effort to deal with traumatic memory, and you do that in cognitive processing therapy by supporting the patient to write about those experiences and to read them on a regular basis. And the vast majority of the effort in this treatment goes to dealing with those beliefs that I talked about. Nobody can be trusted. The whole world is dangerous. A stronger person would have prevented this from happening. So the therapist and the patient work together to address those beliefs very directly. And there are a few different themes that are hit over the course of 12 sessions in this treatment. The primary themes are safety, that the whole world is dangerous kind of belief, power and control. Some of you that interact with folks that have PTSD, do you find that there's an effort by that person to try to control the environment or to control themselves as much as possible? I'm seeing a few head nods out there. And some of that shows up in hypervigilance, not entering environments that have a lot of potential threats, or always having your head on a swivel. Self-esteem and also intimacy with other people can be really disrupted by this condition. And those are particular targets in cognitive processing therapy. So this is the other best treatment that we have. And one of the best outcomes that I have seen unfold in the VA over the last 10 years is that there is a mandate within the entire system for every medical center to have staff that are trained in those treatments. And we have multiple staff at the Sheridan VA in outpatient mental health and our residential programs that provide these treatments very effectively. So there's better access to these kind of interventions than ever before. And it's a really positive outcome in my estimation. So usually when I give a talk to an academic crowd, I spend maybe 30 minutes to an hour discussing research on PTSD, and this is not the crowd for that, I don't think. I don't think any of you want to hear me going through randomized controlled trials for the condition for 45 minutes or an hour, but I did want to just try to put one thing up there to drive home the impact of these treatments that I'm discussing. So there have been a couple of studies done by Patty Resick, who is an investigator in the VA system in Boston University, where she compared prolonged exposure to cognitive processing therapy and followed up with people that had received either of those two treatments 6 months after those treatments, but then, and this is an amazing accomplishment, followed up with all of those people 10 years later, which is an amazing research effort by that department. And what I'm trying to illustrate on the slide is a couple of things. So the bars represent, the blue bar represents the severity of PTSD symptoms for folks in that study before treatment. And just to give you a frame of reference, the highest number on that outcome is 90. And most of the people started in and around 85 to 80 on that measure. So it's very severe PTSD in that large sample of people. And what I'm trying to illustrate is that whether you got prolonged exposure or cognitive processing therapy, at post-treatment and at follow-up, people were a lot better. And there were no differences between the two treatments at 6 months or 10 years later. And those effects held 10 years later. So when I say that the treatments work and the results stick, this is what I'm talking about. And it's a better time to be a PTSD treatment provider now in the VA system than ever before, because we do have treatments that work. And I really couldn't say that, back in the mid-90s, even as recently as then. We have better technology, and I want you all to be aware of that technology so that you can help your folks get access to it. Any questions about the one study before I keep on? Okay. Right. During the introduction, Stella mentioned that I was a professor at Duke University and an investigator with the Durham VA before I came out to Sheridan. One of my areas of expertise was not just the impact of PTSD treatment in veteran populations, but also what was keeping veterans out of treatment. Because one of the things that early in my career I had a lot of frustration about was that I had these good treatments, and there were a lot of people that didn't want anything to do with them. And do folks out there, have you found it difficult to encourage a veteran or somebody that you know that has these symptoms to get assistance? Anybody had that issue? Okay, so at least some people have. Well, if you haven't, it's a real issue, particularly among younger veterans from Iraq and Afghanistan. There is a reluctance to engage in one of these treatments. We did a study at Duke before I left where we evaluated what the primary barriers to care were, particularly among veterans from Iraq and Afghanistan. And what kept coming up when we surveyed veterans was that many of them had negative beliefs or expectations about confidentiality or privacy that existed around these treatments. And it made sense to me because veterans come from a military system in which treatment is not confidential. So in DoD, the Department of Defense, whether you're in the Army, the Navy, Marines, it is often your commanding officer that says you need to go to treatment. And there's no privacy partition between the provider and command, often, in Department of Defense. And many people in the Department of Defense are unwilling to seek care because of their concern about how they'll be perceived by command or how their career trajectory might be affected. So folks socialized in that system are often unwilling to get care when they leave the system because they have those concerns. So another kind of message that I'm trying to get out there that's different between the VA and DoD is that the VA system is characterized by privacy and confidentiality, and there is no mandate to report treatment or the outcomes of it to any authority figure. We're really trying to get the word out about that. There's also, anybody former military in the crowd? Anyone? Okay, somebody in the back. So another thing that kept popping as a significant barrier to care, Stella? Oh, I've only got 5 minutes? Ooh, okay. I'm sorry about that. I'm gonna have to hurry a little bit here. But there's often a stigma associated with mental health or PTSD in the VA, in the DoD system among active duty service members. They often feel like having a disorder, a psychiatric condition, is an indication of weakness, and they reluctant to receive care about it. So what I'm going to try to do is to get into now, and I'm sorry I only have 5 minutes. Is there any way we can stretch a bit? 10 minutes. Okay, I'm gonna try to take 10 minutes because. Okay, all right. Because I wanted to get into recommendations to caregivers, and that's kind of where I wanted to spend the majority of my time. What's that? Yeah. So let me get started with some of these recommendations. All of these slides will be made available to you if you'd like to receive them. And I'm also happy to communicate with anybody after this if you have questions about anything that's on the slides or anything that I don't get to. But some of my best recommendations for caregivers, and probably number one, is that it's difficult to have any kind of successful outcome if the caregiver is not safe. And I wanted to draw this clear line between anger and irritability that are associated with PTSD and violent behavior directed at caregivers. So violent behavior, stalking, emotional intimidation, emotional abuse on a day-to-day basis, those are not symptoms of PTSD, and I do not believe it is a reasonable expectation for caregivers to suffer through those kinds of things. It also doesn't do the veteran experiencing post-traumatic stress disorder any good to suffer through those kinds of experiences. So in order to be successful with any treatment arrangement, the caregiver needs to be safe. And if any of you are in situations where your safety is questioned on a regular basis, I would encourage you to take some action. And, okay. One step ahead of you. So we have an excellent resource in the Sheridan community that has shepherded many caregivers through situations that involve risk for violence. It's the Advocacy Resource Center. Is anybody here from the Advocacy Resource Center? Okay, well, thank you for what you do. I've had a number of positive experiences with caregivers that have worked with the Advocacy Resource Center to negotiate situations involving risk. And I think it's a wonderful resource that we have in the community, and I would encourage any of you experiencing those situations to contact the Advocacy Resource Center. Do you want to provide any information? But some of my best recommendations for caregivers, and probably number one, is that it's difficult to have any kind of successful outcome if the caregiver is not safe. And I wanted to draw this clear line between anger and irritability that are associated with PTSD and violent behavior directed at caregivers. So violent behavior, stalking, emotional intimidation, emotional abuse on a day-to-day basis, those are not symptoms of PTSD, and I do not believe it is a reasonable expectation for caregivers to suffer through those kinds of things. It also doesn't do the veteran experiencing post-traumatic stress disorder any good to suffer through those kinds of experiences. So in order to be successful with any treatment arrangement, the caregiver needs to be safe. And if any of you are in situations where your safety is questioned on a regular basis, I would encourage you to take some action. And, okay. One step ahead of you. So we have an excellent resource in the Sheridan community that has shepherded many caregivers through situations that involve risk for violence. It's the Advocacy Resource Center. Is anybody here from the Advocacy Resource Center? Okay, well, thank you for what you do. I've had a number of positive experiences with caregivers that have worked with the Advocacy Resource Center to negotiate situations involving risk. And I think it's a wonderful resource that we have in the community, and I would encourage any of you experiencing those situations to contact the Advocacy Resource Center. Do you want to provide any information? Thank you very much for what you do and for sharing that information.
The office number is 672-7471. Our crisis line is 672-3222. I should have brought some brochures. Okay.
Well, like I said, I've got the information and the slides, and we can make these slides available to folks that participate. Some additional caregiver recommendations that I would strongly offer is there's an unprecedented amount of resources available either online in the community or at the VA. The Caregiver Support Program, which Shelley Poirier, who is here today, and is the primary coordinator of, is an excellent resource for veteran caregivers to negotiate these kinds of issues and receive services. There are a number of others that are available online or even through smartphone applications that you can see in some later slides. Also, because those barriers to care are so important for veterans with PTSD, I'm going to talk a little bit about ways to overcome those barriers to care. I have really seen peer support be extremely beneficial to folks that are having difficulty engaging with mental health services. We have a number of really effective peer supports operating in the Sheridan system. David Humans and Michael Coffeen are some specific names to mention. There are also opportunities for peer support in the community, and many veterans have received these treatments, and folks struggling to engage with care are often much more receptive to a testimonial from another veteran than me trying to convince them, this is a great treatment for you. So make use of peer support when you have, when you can. There are a number of resources that provide virtual peer support, online testimonials from many other veterans that have PTSD and have been successfully treated in the VA. The websites to mention are maketheconnection.net and About Face. If you Google those things, you will find online testimonials from veterans of all eras that have received these treatments. This is really an option for virtual peer support. Coaching into Care is a free, confidential, and around-the-clock telephone service offered by the VA specifically for family members or social supports of veterans that have difficulty engaging with care. So folks work this hotline, and it is their job to talk to family members or caregivers and help them communicate with veterans in a way that is likely to lead to engagement with care. So there is a resource guide attachment at the end of the slides that has the phone number for Coaching into Care. It's a great resource. I used to work with folks in the call center at the Durham VA, a tremendously effective set of individuals, and they will create a tailored plan for caregivers to communicate with veterans in a way that helps them connect with care. So please do make use of that phone number. Another area of research that we did before I left Durham was to look at not just barriers to care, but what patients wanted from care, what veterans wanted most from care. And often, like I said, anger is a tremendously disruptive symptom. Anger, those intrusions, and emotional numbing really has an impact on relationships with family members. And we should be talking with veterans about what they want to treat most to get them into care. And so get a sense of what is most disruptive to the specific individual that you're concerned about. And the good thing about these treatments is they work for all the symptoms. All of those symptoms, regardless of the cluster, get better with these treatments. Okay. A couple other things that I wanted to mention in regard to caregivers. And probably if I wanted you to remember one thing, it would be this out of today, and that is work with the professional. Engage with a clinician that you have access to in the VA system or in the community if you're a concerned family member or a caregiver for somebody that's suffering from post-traumatic stress disorder. It is, a good clinician should be open to family members participating in sessions and being informed about what the treatment plan is, how you're going to get there with a particular veteran, and what the family member or caregiver can do to potentiate a good outcome. So please inquire about the opportunity to engage with a treating clinician if a veteran that you know is interested in receiving care. There are a number of great resources online to get information about PTSD and very user-friendly for the layperson. The National Center for PTSD website is the best one that I know of. It's on the slides. Also, the National Alliance Against Mental Illness, NAMI, and SAMHSA, the Substance Use and Mental Health Services Association, have great introductory educational material for family members and veterans themselves. Please make use of that. I hope at some point today, self-care becomes a topic of discussion for all of you, because it's my strong belief that anybody providing care to an elderly veteran, a veteran with PTSD, or any other condition should have a specific plan for caring for themselves if you want to be successful helping another individual. That might include psychotherapy, it might include regular exercise, it might include saving time to participate in positive events or enjoyable experiences yourself, but you gotta do that. You gotta do that to be healthy yourself. All right, I'm sorry I having to rush through a lot of things, and my time has come to a close. I had planned to end with a discussion of specific strategies that you might use as a caregiver to get through the difficult times when folks are experiencing spikes in particular symptoms. A lot of those recommendations are intuitive and wouldn't require a lot of explanation from me, and they're up there on the screen for you. They will be available to you after today's conference. Yeah. Wonderful. Yeah.
Take a little more time because we planned on an hour for lunch and we're going to be in here anyway, so we're still going to eat and we can take 45 minutes for lunch. So just, I don't want to lose any of this. So just.
Okay. Well, I don't want to keep anybody from eating. Let me ask this: does anybody object to that? To taking a few more minutes? Yeah.
This is giving video for.
Oh.
This is giving video for the caregivers of the VA that could not make it. And
Okay.
most of them are the post-911 caregivers.
Okay.
And so I would really appreciate it if you could finish it and we could cut the lunch a little short. Please.
Is that gonna be a problem for anybody to delay lunch just by a little bit? Okay, well, thanks for your flexibility. I appreciate it. And I think this is some of the, I hope to be the most useful information to share with you. And if Dr. Crawford, the other Dr. Crawford, can revisit some of this during her discussion, that would be fabulous as well. So there are a couple of recommendations that I would have that make a difference with all the symptoms that I mentioned earlier in the presentation. And I've already mentioned the number one thing is to work with a professional. We have very well-trained professionals in various disciplines, psychology, social work, LP, MHCs, that are trained in these treatments. And to get the best effect, you need to work with somebody who knows what they're doing. You know, don't try to take on these symptoms alone, and it is not, you shouldn't, in my opinion, you shouldn't perceive it as your responsibility to deal with these symptoms in isolation. That's a pretty difficult expectation to have as a caregiver. So please do work with professionals. We have them, make use of them. And another thing, and I think this probably goes without saying for most folks, is that all symptoms get worse when you introduce alcohol or intoxicants into the equation. And this is true for patients with PTSD, but it's also true for folks that are trying to provide care to folks with these conditions. So if you consume an excessive amount of alcohol, other substances, it really impacts your ability to react effectively in the moment, to sleep yourself, or to just be able to weather the caregiving experience. So I would encourage you to try to do what you can to limit your consumption of alcohol and other intoxicants. A tried and true way to get through very difficult moments where people with PTSD are experiencing intense intrusions, those memories intruding into day-to-day life, is to try to introduce some kind of competition for that memory. What's happening is that when somebody's experiencing an intrusion, that memory is trying to hijack the person with PTSD's brain. And what you can do in a lot of situations, and caregivers can assist with this, is to create competition for the memory by using other stimulation in the environment, whether that is using touch and really feeling what's in the environment, especially like if you have a squeeze ball, if there is something like in the environment that has a rough touch to it, like these chairs do. The wall in my office at the Durham VA, for some reason, had carpet up the wall. And when people were experiencing a lot of intrusion, it was very rough carpet, almost like sandpaper. And feeling that can really help ground somebody where they are and help them understand that they're not in Iraq or Afghanistan or Vietnam, that they're in the present. You can also do that with visual stimuli, so you can try to orient people to what's around them visually. And then what I call kinetic grounding can also be really useful. So moving, getting up and taking a walk or something like that can really give your body and mind information that you're not experiencing that trauma, that you are where you are. We're here at the Wesleyan Church. The best way for me to understand that is to feel where I am. So that's something that you can do to deal with intrusions. As I mentioned, anger can be a really disruptive symptom for both veterans and caregivers that are dealing with this condition. Some of the best advice that I can have about anger is trying to get to a place where you and the person you're providing caregiving for understand that their anger is escalating. So first start monitoring it, and whether you use like a 0 to 10, 0 to 5 scale, you want the person you're providing care for and you yourself to understand when the thermometer is going up. It's really hard to deal with anger when you're a 9 out of 10. If you can get in the habit of having a rapport with the caregivee and understanding, okay, I'm getting frustrated, I'm at a 5 or a 4, then you can do something about it. So monitor, and also I would encourage you all to have conversations about, can we, when you're getting into the danger zone, can we figure out a way to take a timeout or a break, exit the conversation that we're in, engage in an activity that has an impact on anger, whether that's physical exertion, a walk, reading, etc., and then come back to that situation after the timeout. So, but that needs to be done collaboratively between the caregiver and the veteran or the patient. But it's really difficult to do that if the volcano is exploding. So monitor along the way. Emotional numbing, like I said, very difficulty experiencing positive emotions is part and parcel to PTSD. And one of the best things you can do there is empathize with the person that's having that experience and understand that it's a part of the disorder, that it doesn't necessarily mean that that person does not love you or a child in the family. It's just part of the condition. And it doesn't have to be forever, and you can have an improvement in that symptom through successful treatment. And emotional numbing, one of the best ways to overcome it is to figure out a way to still participate in enjoyable experiences with the veteran that has post-traumatic stress disorder. They might be unwilling to go to a movie and sit in the middle of the crowd on an opening Friday night, but they might be willing to sit in the back with you during a matinee in the middle of the week. Or they might be willing to go to a small coffee shop with you and sit in the corner and enjoy some good food. So be creative about how you can introduce positive experiences or enjoyable events with veterans that have these conditions. The triggers and cues, that goes back to the tasty cakes. So trash on the side of the road is a huge cue for many veterans from Iraq and Afghanistan. Tree lines, anything having to do with military paraphernalia can be a significant reminder. So my best advice there is to, again, work with a therapist to understand what those different cues and situations are, and think about ways that you can slowly but surely help your family member or caregiver understand that the cue doesn't have to mean life threat. But you start small. You don't want to jump into the deep end of the pool and go after the most difficult cues and situations first. You want to start small and work with a professional. Had a number of patients in and around the Sheridan area communicate to me that, that one of the ways that they are effectively able to deal with that drive to engage in reckless behavior is to do something that out in the environment that gives you a little bit of adrenaline but doesn't have risk. Like driving in traffic at 100 miles an hour is pretty risky, but going hunting, bear hunting, elk hunting, something like that, that provides a channel for that kind of adrenaline seeking that doesn't have to involve a lot of the negative consequences. Also, really vigorous exercise can be a way to get some of that kind of sensation without the negative impact. And of course, let me give the disclaimer that you always want to get agreement from your physician to engage in vigorous exercise before you do it, but that can be a way to channel some of that adrenaline and actually lead to better health than damage to the body and the mind. So I think I'm just gonna, because I know I'm way over time, I'm gonna end with sleep disturbance, and again, the other Dr. Crawford can highlight some of these symptoms when she provides her presentation. Sleep disturbance for veterans with PTSD or patients with PTSD often worsens the sleep of the partner. Especially if you're a spouse who's a caregiver, it can be very difficult to have a successful night's sleep with somebody who is thrashing about because they're having nightmares or gets up multiple times throughout the night. And one of the ways in which that can be dealt with just instrumentally, and it doesn't have to be forever, is to take some time sleeping apart. And often that leads to a benefit for the caregiver, but also the person experiencing PTSD. And it doesn't have to be forever. It doesn't have to impact your intimacy with the person if you do it strategically. That's something to consider. And then there are a lot of good resources online for good sleep hygiene. And part of my best advice to caregivers is to use good sleep hygiene. And for veterans with PTSD, use consistent wake and bedtimes. Make sure that the room that you're sleeping in is as quiet and dark as possible. When you get up in the morning, try to access some light. Good natural light, like we have here in Wyoming, is a wonderful resource to set your biological clock every morning. And in today's world, many of us use electronic devices. So who's brought a smartphone with them today? Okay, just about everybody. So I have two. I've got like a bat belt that you can't see that has various smartphones here. And the smartphones are great tools, but they can also be really damaging to sleep. The light on the screen late at night, the mental connection with a device that gives you messages from people and leads to entertainment potential can really mess with your sleep. So I would encourage you all to turn off your electronics maybe an hour before bedtime. Leave them outside of the bedroom. There are many other recommendations that have to do with sleep hygiene. Again, you can find them online. Those are some specifics. So again, I want to apologize for going over time. I hope at least some of this has been useful to you in maybe understanding PTSD and knowing what you can do as a caregiver and understanding some resources that you can access, whether they be online, at the VA, or in the community. And the last slide in the set has a very comprehensive pocket guide of resources that may be useful to caregivers of veterans. So the caregiver program is mentioned in there, National Center for PTSD, Coaching into Care, and various other smartphone apps that can be successful in helping people recover from PTSD. So thank you for your time, and I'm gonna hand off.